Assalamu alaikum. So I think all of you know about me. Here only I see Dr. Aisha. Okay. Dr. Huma is not known to me. Okay. So I don't want to go for in details my description. So I am with the MRCPCH part 1 and part 2 for a long time. Okay. And trying to to description and try to help everyone with I have a group for part 1 and part 2. So my part 1 students are going to give exam, and for them I just now starts to recall discussion for everyone. Like I will start from today, and inshallah I will cover every topics and most important things, the problematic question, but I will try to give more emphasis for the last 2 years question. If you have limited time, then also you can focus on this. But before recall discussion, I want to say that recall discussion should not be like to pick up only the right answer. It's not like that. You have to have some conception, because in each recall question, sometimes recall are so poor, we cannot make a definite diagnosis. So in that times, you have to understand the way we are thinking, the way we should thinking. And sometimes when we go to the exam, that you can understand that actually the question was not like the way in the recall paper written. The question is different. Okay. So if you know the topics and surrounding the recall, you can easily pick it up. So sometimes the recall is so clumsy and we are thinking over this and give much time, but in real exam, we will find that no, the recall paper is saying something, but actually the question is different way. Or they can make question different way. Okay, it's not like they take the question all the time same way. They can take question slightly different way. So we have to know it. And mainly question was confusing with the FOB paper. So we will try today to give to discuss about the FOB paper. Okay. So it is the first question of 2023. So I see cardiology related question was less if I compare with the GIT, neuro, and other papers. Cardiology related question actually less. In the FOB we get 1 to 2, 3 these types of question. Okay. So, and most of the questions are very clear cut. Cardiology is very clear cut like math. Okay, you know. So first of all, you see child 3 months old with mild dysmorphic features, saturation is 95% with loud systolic murmur all over the precordium. Patient is not cyanosed with failure to thrive. So your task is to write it in the chat box. Okay, what could be the right answer? I will see. Even you can directly give this question to me also. What do you think? What could be? We have not much time, so you have to write it rapidly. Okay. Everyone should involve. Okay. So here they want to say, mostly we get the right answer. But you should think over dysmorphic features, and patient is not cyanotic. And acyanotic heart disease, even if they do not say about cyanosis, you should check about saturation. What is the saturation? Is it normal or abnormal? And there is a systolic murmur. Is it systolic murmur? Okay. but they do not say where it is, because you know, some, especially in the pediatric age group, one murmur would be all over the precordium, is heard like this way. Most accentuated could be different. So it is VSD, and most probably they indicate Down syndrome. Okay, Down syndrome murmur is systolic murmur, pansystolic murmur, more marked at the left lower sternal edge. Murmur, you should have a very clear conception with the murmur. Okay. Then next question. Then another question was systolic murmur on the second right and suprasternal region, thrill is 4/6. So the murmur grade is very high. Okay, very high. So what do you think? What could be? So here 11 persons try to invoke 11 persons. Okay, 11 persons try to invoke. And if you find it is if you hesitate, you can directly message me. Okay. So you here, when there is murmur on the right side, so always we are thinking about aortic stenosis, and it can be radiate to the neck. Even suprasternal region we can get murmur. And it is thrill, not always, but thrill here they've written. So aortic stenosis murmur, right-sided. Okay, we have to be careful on these things. 2022 do not get any question. June 2022 there was some questions. Recall was not complete, but there was written in the bounding pulse. So where we can get bounding pulse, where we can get central cyanosis, where we can get 250. So actually, it's very incomplete questions, incomplete recall. But we can say bounding pulse is PDA. Yes, PDA. Yeah. Thank you. And central cyanosis would be any cause, cyanotic heart disease, need patient age, and many things. Otherwise, how can we say? But when we get any patients after birth, within 48 hours, there is cyanosis without murmur, we will take TGA first, okay? But after birth, initially you get the cyanosis and there is no murmur, you will take TGA. And rate around 250, what does it mean? Supraventricular tachycardia, sometimes they think, or sometimes they say it is WPW syndrome, okay? So thank you everyone who participate here. Mostly you get the right answer. Now, 5 months, 39 weeks, systolic murmur, grade 3/6 at left lower sternal border, blood pressure in the right arm, 65/35 right leg. So they say some blood pressure, you see no basic difference, okay? So saturation is high. What do you think? Saturation, cyanotic or acyanotic, and then there is a murmur, 5 months age, and it is left lower sternal murmur. So it is very easy question, nah? It is very easy question for us. Yeah. And then if you go for 34 weeks gestational age, coming from 6 weeks follow-up, ejection systolic murmur, grade 3/6 at upper left sternal border, normal heart sound, right arm 65/35, right leg. So they indicate that any postural hypotension, or any pressure difference in between right to leg, right and left leg. So they wants to know coarctation of aorta is there or not. And saturation is normal here. So 34 weeks and you get ejection systolic murmur. It is upper left sternal edge. So who can say me upper left sternal edge, which murmur we get? It could be, if we take upper left sternal edge, then it could be pulmonary stenosis. it could be. So pulmonary stenosis murmur also is a component of trough murmur. Also, we can get aortic stenosis murmur. So PDA murmur is mainly below the left clavicle, but we can find it here also. And there is coarctation of aorta. So here, what is more suitable? 6 weeks follow-up when the patient having these types of murmur, we have to think upper left sternal edge. We cannot think about here ASD murmur, that is atrial septum defect murmur. Usually they mention the first and second have some characteristics and they radiate to the back or not. Okay, so we have to think over here PS. And then 10 days preterm baby, 34 weeks long. So actually pulmonary stenosis murmur presented two way. One is early age presentation like this sometimes, and usually the presentation is lately also, okay? And then second preterm baby, then there is murmur 2/6 upper left chest best heart at the upper left sternal border. Blood pressure right arm 75/35, right left or right arm and right leg same saturation. So preterm baby if they are, then PDA is always our first priority. So it seems that the murmur related questions is more here, you see. And another thing is some confusing questions are there. I marked it red. We will discuss later, but mostly nowadays question is not very much confusing with the CVS. Okay, again, I think it is saying, okay, let's see, 2 years old with loud systolic murmur at the mid-lower sternal border with field BP 105/75, saturation 97%, femoral pulse volume equal, not delayed from right brachial plus, apex is 5th intercostal space, just lateral to the nipple line, auscultation, splitting in the second heart sound, variable with respiration. So what do you think? So where is the murmur? Always we have to see first age, 2 year, and now systolic murmur, sternal border, BP was okay, saturation 97. Femoral pulse is volume, okay, apex just lateral to the nipple line, auscultation splitting. So if they say you these steps of splitting, what do you say? Okay, apex is also displaced, lateral to the nipple line. But auscultation having displaced second heart sound, splitting second heart sound. And then it is variable with respiration. Another question, 5 years with left sternal border. Okay. 5 years with left sternal border, loud systolic with ejection click, BP 105/75, saturation 97%, femoral pulse volume equal and not delayed from right brachial, auscultation splitting second heart sound with variable with respiration. So something is very common, it's EMQ, okay? Okay, it is EMQ. And ejection click is there. Here we just get new things, left upper sternal border, loud systolic with ejection click. Okay, left-sided, but there is ejection click, something they want to mention something. Okay. Okay, then 6 months with soft systolic murmur at the left upper sternal border. BP saturation was okay. Femoral pulse volume lower, but not delayed from right brachial. Auscultation splitting second heart sound volume with respiration. Okay. So 6 months you get it, and of course it is systolic murmur. Left upper sternal border. Pulse volume is lower. Okay. Okay, that's good. That's good. So this is the typical question. Usually they give this way, and you made it. Okay. You made it very good way. This question is a confusing question, and I have some opinion regarding this. Teenager girl complained to her teachers that when she participated in school sports activity, she had attacks of palpitation and tachycardia. She had a history of 2 similar episodes in the last 6 months. What is the investigation that helped in detecting the underlying cause of her palpitation? So for this question, in our previous lecture, we discussed about the tachycardia, okay, and palpitation. How can we evaluate palpitation and tachycardia? If you go through the pediatric guideline, even if you go through the in my PDF, you can say the way how to we evaluate. And there they do not mention patient event recorder. Okay, they do not mention it. It is only we have to do it when we are thinking that it is a psychological induced. Otherwise, we have to do the 12-lead ECG. Although you see it is in the key, they mention it that it is patient event recorder, but I never heard in anywhere that it is patient event recorder. But I pick it here, just I do not change the color because sometimes you think that it is recall paper is always right, but it is not like that. Okay, recall paper is not always right. Okay, so if we check our that how we have to manage tachycardia, palpitation. It's very important. I said that palpitation related questions was less, but nowadays they give it in the pediatric guideline. It is so they will give questions from here. Okay, I think here is syncopal attack, cardiac neurological cause, psychiatric cause, orthostatic tachycardia syndrome, palpitation. Okay, so palpitation, tachycardia, just it is from the pediatric guideline. There are different cause. So when you get a patients of palpitation, you have to take the history and very important things, you have to evaluate the cardiac cause. So how can you understand that cardiac cause could be there? So here you have to look for patient, some history is very important. Patient developed tachycardia and like palpitations, especially when they do exercise, sometimes they lose consciousness. It indicates some cardiac origin, it could be. And also family history of cardiac disease also important. They mention in the pediatric guideline, you see, associated with exercise, syncope, pre-syncope, known congenital heart disease, positive family history, abnormal examination, 12 ECG. And non-cardiac cause even there, but you have to do the ECG. Both cardiac, non-cardiac, whatever you are thinking, you have to first go for ECG. Then if you do not find anything, or you have to more consciousness for this, more query with this, you can go for ambulatory ECG, okay? Ambulatory ECG. So remember this chart very well. Okay, if cardiac origin, you have to discuss with the pediatric cardiologist. If you get ECG normal and patients having no cardiac risk factors, then no specialist input is necessary. So you have to remember this way. Okay. So where we are? I think you understand that I do not agree totally with this patient event recorder. It is mentioned as a right answer in the recall paper. Okay. It is a. Then 1 year had viral infection and mother complaints of difficulty of feeding, breathlessness, heart rate 190, respiratory rate 45, liver 3 centimeter below the costal margin, bilateral capitation, normal. Here you can understand it is totally features of heart failure. Okay, I hope you understand. Yes, Dr. Amma Salma. But from pneumonia could be heart failure. Cystic fibrosis can have precipitation. Bronchiolitis also could have some feeding problem, breathlessness. So why it is viral myocarditis? So bronchiolitis having not like viral infection, then they develop many things they can develop, but hepatomegaly no. Okay, and bilateral basal crepitation always indicate that there's some fluid in the lungs, so it may be pulmonary. It's actually pericardial congestion, and it indicates heart failure, and it is the most common cause, viral myocarditis. Okay, and there are associated more questions with this. What is the cause of viral myocarditis? Common organism. After viral infection, Coxsackie B virus. It's you will get it later. So child during playing rugby collapsed and regained his consciousness immediately after that referral to the hospital, and at the hospital was fully conscious and examination was normal. Which investigation will you perform? So you have to understand that is it, what's the diagnosis actually? Then you can, okay, so who understand this? Yeah, it is ECG. It is, we are not thinking that patient is, neurological cause is not. So something behind that, which cardiac cause could be behind it? During like doing playing and then lose consciousness. Okay. Which things could be behind this? What do you think? Yes, long QT syndrome. Usually long QT syndrome. Okay. But you see, after referral to the hospital, and hospital was fully conscious. Okay, examination was normal. So it is very important that a person's loses consciousness during playing. We know long QT syndrome, various way of presentation, sudden emotional attack. They have playing and then happen, and family history of sudden cardiac death. So these all are important and in favor of long QT syndrome. And we know how to make diagnosis, I hope. Baby presented with history of gastroenteritis, upper respiratory infection. After then, he developed tachypnea, heart rate 190 with gallopridom, capillary filling time 4 seconds, weak peripheral pulse, hepatomegaly first. Okay, so what is the causative organism? Okay, so heart failure. So why heart failure, and which organism could be here? Yes. So adenovirus. Okay, so Coxsackie B is important, but adeno also can cause. An organism name is always important for every exam. 14 years female had fatigability, although we are thinking that organism name is for the TAS exam. No, it is even in the AKP exam, they give an organism name. Okay. Now, so some are so rapid, you see, inshallah, you will be very good in the exam. They just see and make their diagnosis. So infective endocarditis is very confused with rheumatic fever, because yes, rheumatic fever could be some murmur, but the splenomegaly not goes in favor of anything here. Okay, it's not goes in favor of yes, not for other things also. And clubbing. Here clubbing, infective endocarditis could be clubbing, there could be diastolic murmur, okay, night sweating. So these are the things. So not always for infective endocarditis, they will have some congenital heart disease is there. It's not like that, okay? So you have to make your diagnosis. Sometimes there is a question for infective endocarditis, what is your investigation? So we'll discuss when the questions will come. Okay, mother known have a SLE, recurrent miscarriage, what is the most serious complication could affect the baby? Yes, complete heart block. It's not first degree, second degree. It could be asymptomatic. Completely heart block they can develop pleural effusion and then all the features of heart failure, and ultimately the complications become more severe. Okay, so we are just concerned with this. Investigation is not asked here, but I think it is investigation asked elsewhere. Okay, so like anti-RO is for complete heart block, anti-LA, that is the antibody, is for skin related. Okay, so RO is very important for cardiac evaluation of a SLE mother who developed, the baby developed some cardiac complications. Now this question is, I think this question having argue with everyone. Okay, we have many argue. So I just, I want to show you where is our argue point. Okay, so don't make a diagnosis now because the questions come in the exam different way. Many different way this exam come, even if these questions came in my exam, it is totally different way that we discuss. So first of all, that you see, argue with the mother. After that, when father comes, stepfather, then they went to the bed and stand up, got pale and fall to the ground, twitching of her, rapidly recovered. Then remember, she was dizzy before, there is posterior step epilepsy. So if I say that it is syncope, so syncope how could be? Syncope is sudden loss of consciousness and they rapidly regain their consciousness, and it is within 30 seconds, not minutes. And this time, what happened due to stress, sudden stress, due to fasting or crowd, excessive sweating, different cause could be. Okay. So for these types of patient, they can develop some abnormality of their hands or twitching movements in the hands or some anoxia in the brain. So it can develop some seizure type events. That is the twitching of the hands. So rapidly recovered is another point in favor of syncopal attack. But complex partial seizure, if you consider complex partial seizure, then also it could be. Because complex partial seizure also they'll regain their consciousness within 30 seconds to 2 minutes. 30 seconds to 2 minutes. And it positive family history of epilepsy is points in favor of a complex partial seizure. And complex partial seizure could have these types of twitching of the movements, but patient got pale. It is not in favor of our complex partial seizure, because for this they have to go pale. It's not like that. So here differentiation points in the real exam is the duration. If they said it is like 1 minute, 2 minutes, especially 2 minutes, then you cannot go for syncopal attack. So some questions, same questions I see, they give for, sometimes they give rapidly. It is not mentioned how rapidly, but if they said you that after 2 minutes that they regain their consciousness. So it is not syncope here. It's 2 minutes they remain unconsciousness and then get the regain their consciousness, it's not possible. So in that cases, you will choose complex partial seizure. And another things you should remember, remember that complex partial seizure have to be they lost their consciousness. Simple partial seizure means they have some abnormal movements, some part of the body, and they do not lose consciousness. It's simple partial seizure. But complex partial seizure means they lost their consciousness. Okay. But for this question, you see, she remembered she was dizzy before. Okay. So loss of consciousness is here or not, it's not very much clear. So what I say, you have to remember these points. Okay, and then take your decision, especially duration is very important here. Is it clear? Or any questions from here, from these questions? Okay, actually, I want to clear it so that you can take your decision appropriately. So I said here syncope, and you go there with the 2 minutes unconsciousness and you take syncope. No, it's not possible. Okay. So October 2020, they cause narrow complex. So you know it, it is supraventricular tachycardia. So what is the drug of choice? When there is tachycardia and more than 250, actually, narrow complex, it is called narrow complex tachycardia. Then there is adenosine, you know, it is the drug of choice, IV adenosine. Okay, so let us see again, what is this? It's another important thing. 12 days old baby girl with 2 days deterioration and lethargy, poor feeding, lymphedema, weak femoral pulsation, murmur 2/6 with normal heart sound, capillary refilling time 300% oxygen, but no oxygen saturation. What drug to be? What drug to be given? Sorry, Dr. Homa, I mute you. Okay, some sound come. Okay. So you see, it is 12 days baby, and lymphedema in the hands and feet, why they mention. Can anyone comment on this? Lymphedema in the hands and feet. Weak femoral pulsation. Murmur 2/6 with normal heart sound. Murmur 2/6 means it is not usually systolic murmur is loud. Okay, so you know that in some syndrome there could be lymphedema, like actually we are mainly thinking of Turner syndrome. Okay, they have lymphedema. Okay, and they have high chance to develop coarctation of aorta. They can be developed early even. So in that cases, we will get weak femoral pulsation, and not always they are presented with like cyanosis. It's not like that. Mainly their presentation is sepsis-like presentation, shock-like presentation. Okay, and another thing is coarctation of aorta is something called, it is yes, Dr. Nomani, yeah. So in that cases, you will get patients having, it is systemic circulation dependent, okay? It is systemic circulation dependent problem where systemic circulation is not appropriate as duct closure. After birth duct closure, so coarctation of aorta was there. So how the blood supply will be rest part of the body. So when duct closer, then it creates problem. Before then, with the ducts, the blood supply was okay. I think you understand this. Okay, so pulmonary trunk and arch of the aorta, as when we are in the womb, then their lungs are not active, or we do not need to lungs activity. So that times there is a communication. Okay, that is the duct. So after birth, lungs when functioning, that times when the lungs functioning, this duct is not required, and according to your pathophysiology, it will be closed. So arch of aorta will be normal functioning. So before, with the duct, the blood goes to the rest of the body. Although there is some it is before usually here is the problem. Okay, closer. Intrauterine duct here, closer was arch of the aorta, closer is here. So coarctation is here. Okay, so easily the blood is flow. But after birth, when duct closes, then what happened? This blood cannot be goes out. Okay, cannot be goes out. So the rest of the part of the body is get less supply because anaerobic metabolism, lactic acidosis. So important is to give prostaglandin infusion. The prostaglandin is the causative factors which due to deficiency of prostaglandin, when we are separated from our mother, placenta is produced prostaglandin. So we separated from our mother. So prostaglandin synthesis become less. So it causes this rapid closure. So we have to give prostaglandin to maintain this patency. We get some time, then we send to the surgery department. They will do something if required. Okay, so prostaglandin is it is duct dependent closure of systemic circulation dependent duct problem. Okay, so prostaglandin infusion is very important, and you will get more questions with this. Okay, nowadays these types of questions they like. Okay. So again, question is something rheumatic fever, which is important to rule out or in aesotitarius. So aesotitarius is very important to rule out and in. If you see the diagnostic criteria, then you will say that every diagnostic Jones criteria is there. Then they say that provided the patient's having history of streptococcal infection, which can be characterized by aesotiter. 12-year-old girl was previously healthy, history of hurting her left shoulder, and she did nose piercing, which made infection to skin and responded to topical antibiotics treatment. She is presented now with fever and murmur on apex. Ask about investigation. Previously healthy. Okay, so you see infective endocarditis, but it is, you see nowadays they get less infective endocarditis from congenital heart disease rather than they get infective endocarditis from tattooing, okay, or drug user, IV drug user. Investigation. So what you want to say, I see. Blood culture. Okay. So only blood culture could not be make diagnosis. You know, only 30% case blood culture is positives, and it is said that repeated blood culture. Repeated blood culture is only can give you some investigation. It is infective endocarditis. So some organism is there, but only 30% case we can get the culture, and also the blood culture have to send repeated. 5 blood culture you have to get. So echocardiography is important. They can say now modern echocardiography is very much important. They say the vegetation, and also in the AKP master course book, if you go through there, they mention it is the echocardiography is the diagnostic investigation. Okay. Hopefully, inshallah, I will post echocardiography where it is written, master course book it is written, which is from RCPCH recommended book. Okay. I think you can have some confusion here because blood culture echo both are written here, but echocardiography, when they ask you one, and the diagnostic investigation, you should go for echocardiography. And the evidence I will post. If I forget, please remind me, okay? Child with small VSD need elective tonsillectomy. The ENT doctor needs pediatric consultation about prophylactic antibiotics. So VSD, small VSD, it is not required for prophylactic antibiotics. Okay, you know, where we have to give the prophylactic antibiotics. It's very clear. I think all of you know it, but please go through where I have to give you prophylactic antibiotics, especially not large here, not large. It is depends. Large VSD, okay, because large VSD have less jet flow. Okay, small VSD have more jet flow, so some injury could be on the endocardium. It is written most important previous infective endocarditis. Hypertrophic cardiomyopathy also they mention. And also they mention congenital cyanotic heart disease. If it is not properly repaired, and if repaired, then up to 6 months we have to give. After then, not required. And cyanotic heart disease, it is not any role. Also, if there is reflex, that is regurgitation, so it can cause some injury, regurgitation. And if injury happen on that side, they could be, the organism can grow. Okay, so very much clear idea should be here about prophylactic antibiotics. So again, please go through the file, recall file, and see what is the indication is mentioned here. Female baby 6 weeks not dysmorphic, presented with third G4. So you it is repeat. It's also repeat. It is another thing. Heart failure. What surest signs of heart failure? What is the surest sign of heart failure? So you see peripheral pulse could be weak in shock, cyanosis could be different cause, pulmonary cause, even pedal edema. Even in nephrotic syndrome could be, hepatomegaly also could be proteinuria malnutrition, but neonate hepatomegaly is usually present up to 3 centimeters. It's very confusing, but it is, I got it in pediatric guideline. They mention hepatomegaly is the most important things. In the pediatric guideline, you will get it. They mention, just specifically mention the hepatomegaly is most important. Child 7 years have infrequent SVT attacks. Mother is always if it's attack outside, what to do? So for SVT, recurrent attack, what drugs given? It's not like that if it happened outside. So when we get a SVT patient, of course, we have to counsel them how to take care. So we have to say something that if it is like not infantile age, okay, so infantile age, they can immerse face in ice water, but after then when they can follow command, inflate the new balloon. Okay, so what happened when they inflate, then there would be some negative feedback and parasympathetic overactivity would be there, then the pulse rate would be reduced. It is also same question. Okay, we discuss it. So you see PDA, VSD, PS related question is very common. And Down syndrome patient VSD, then splenomegaly, hematuria, they are also infective endocarditis, very clear. ALA and from ALL, hematuria is very, very rare things. Okay. It is a repeat question. Repeat question. So repeat question. Child ejection systolic murmur on right sternal margin radiate to the neck with frill. What could be? Okay, so it's a repeat question. Okay, we understand that it is S, right-sided sternal margin. So right-sided murmur is not very much like not many murmur. So you should not forget this. I think these are the repeat question. We discuss it. Okay. So here the question is something, yes, new. So look at this question. So it is aortic stenosis. It is not regurgitation, okay? So do go for prophylaxis. Yes, very clear cut. We have to go for no prophylaxis. If patient develop symptoms, then that's a different issue. But we do not have to go for prophylactic drugs. And another thing is whatever the operation, genitourinary, respiratory, anywhere. So it is again here, ear piercing, night sweating, develop look, it's infective endocarditis. But if they give you repeated blood culture, you can take it, okay? As investigation. Boy collapsed during a hockey game, slowly regained consciousness. Yes. So ECG, you see, every time these questions come different way. But recently they changed the question pattern for this. Okay. Every question is same. I think just you see scenario with viral infection, then 1/6 mid-systolic murmur. What is this? Okay. So you said 8 of, okay, 8 of, okay, yes, agreed. But I want to say, what is the answer for C? Dr. Nomani said innocent. Okay, yes, Dr. Masadik, it is innocent murmur. Okay, thank you. So after viral infection, you get it. Yes. And murmur grading is very low. It is already we discussed, repeat question it is. So it is the question of discussion. A girl 3 years ago previously fit well with no health problem. Come to admission unit, her BP is 136/90. The best reasons to explain this. You get PP1 patients. Yes, so you can't say the patient is hypertensive until you measure BP 2 times. And another thing is for BP measurement, the ideal way patient will be sit properly, and after 5 minutes of arrival, and then you will take the appropriate cough, okay, then you can say. So they just said that previously feet no head problem, come and then BPS. So child could be apprehensive, so they can get this blood pressure. Okay, so you get that cardiac related, FOP related discussion is less, but you should not miss one questions from here, okay? After then, if we go for task question, so task related questions actually, you have to memorize it, okay? Again, same type of questions, bounding pulse, fixed beating, second heart sound, from which it is related. And is it showing or not? I think it's not showing. Okay. So here you see something is very similarity with the FOP also, that pounding pulse, fixed beating, second heart sound, high blood pressure. So high blood pressure, some cardiac condition could be related with high blood pressure, especially if you think then aortic stenosis, hypertrophic cardiomyopathy, they have left ventricular hypertrophy. So you should remember this. And now you get some murmur radiating to the back with left ventricular hypertrophy. So which murmur could be like this? Task question is not very much used also. So no problem. Always remember aortic stenosis is very important cause for high blood pressure, not pulmonary stenosis. But if you say that, okay, so aortic stenosis murmur is usually not radiating to the back. Usually they're radiating to the neck area. But it is an important cause of left ventricular hypertrophy. So murmur radiating to the back is pulmonary stenosis, but pulmonary stenosis usually not is an important cause of left ventricular hypertrophy. Okay. So here pounding pulse related to PDA, fixed plating, second heart sound is aortic stenosis, atrial septal defect, and high blood pressure for aortic stenosis. Okay. Mechanism of closure of foramen ovale. Okay, so you see this question is different. So you have to give, you have to read this. Yes, pulmonary vasodilatation. When pulmonary vasodilatation, then the more blood goes into the left atrium pressure increase, it gives pressure, then right atrium in between the left and right atrium, the foramen ovale, it will be close. Okay, so before birth there is mainly pulmonary vein having high pressure, but after birth it becomes low. Okay, due to several mechanisms that we discussed in our class. And persistent pulmonary hypertension and echo finding, what could be? Okay, doctors. Remember, persistent pulmonary hypertension, that means pulmonary pressure should be low after finding anyhow the pulmonary pressure could not be low due to some insult or sometimes meconium aspiration syndrome, sometimes some lung disease. It can cause different cause. So long time, oxygen dependent, so they can develop pulmonary hypertension. It's called persistent pulmonary hypertension. In that case, they have high chance to, when there's increased pulmonary pressure, then what happens? It can give, it can produce give pressure on your right side of the heart. Okay, so in that cases, it will create problem in the right side, and right ventricular hypertrophy could be, it's chronic problem. Persistent pulmonary hypertension is not a sudden problem. Okay, so it's chronic problem, and this persistent pulmonary hypertension. So where is the pulmonary trunk arise? From the right side. Then right ventricular hypertrophy could be, if there is right ventricular hypertrophy, then tricuspid valve become, I can say this word, loose, and they can regurgitate. Okay, so aortic regurgitation is different place. It goes more on left side. Pulmonary stenosis, usually why the valve becomes stenosed. It's not related with the persistent pulmonary hypertension, so that we can get tricuspid regurgitation. So I hope you understand. Any query, please ask me. Total anomalous pulmonary venous drainage, TAPV, they create no features until they have something. So what is these things? Yes, obstruction to the pulmonary vein. When the obstruction to the pulmonary, what is the problem to anomalous pulmonary venous drainage? Pulmonary veins opens instead of pulmonary vein opens where? Normally left side. So they open on the opposite side. Then it creates problem, but it will create problem initial of baby's life when there is obstruction to the pulmonary vein. Okay, and their presentation would be like cyanosis. Okay, so remember these things. So I see here it is more clinical questions here for the TAS exam, but so that I always say that first take preparation both for TAS, and then if you are not much confident, then you can give separate exam. You can book separately, but it's not very wise to read only TAS. Okay, term baby with spontaneous onset of labor after transition to extrauterine life with indicate normal cardiovascular and anatomy. So here actually they discuss about the changes. Okay, the changes. So what is the main issue here? Catecholamine, removal of placenta. Placenta give oxygen by umbilical artery. Very few pulmonary vascular resistance. When we think that it is normal, which statement is normal here? Yes, Dr. Salma, very right. So it is the removal of placenta resulting in increase in left atrial pressure. Okay, so it is not a catecholamine. It is catecholamine never help fluid clearance from lung. It is spontaneously cleared. Placenta give oxygenated. It is given like placenta give oxygenated blood via umbilical vein. Very low fetal pulmonary vascular resistance. No, normally high, then after it becomes low after birth. So here, I think they have many questions. So sleep-related question, how the body responds to hypoxia. So when there is sleep-related and develop hypoxemia, then there is mainly one thing is responsible. Which things? Respiratory center or carotid body chemoreceptor, vagal nerve stimulation, gestural, yes. carotid body chemoreceptors. Okay. So if you go through this, you can understand more, and you can go to the link also to know that how the carotid body chemoreceptor work during sleep. And some ECG related questions always, I said that some questions would be there. What indicate P wave, what indicate L wave, and ventricular relaxation. Ventricular relaxation is there, then what could be? How can you understand? Ventricular relaxation means diastole, okay? And it indicate by the T wave, yes. Ventricular relaxation is T wave. So you have to know everything over the things, P wave ventricular contraction, Q wave P wave atrial contraction, QR is ventricular contraction, okay? And that things. If you forget, then you have to go through. Now, child develop, sorry, I should put this. Okay, so where I am. Okay, so here they indicate that potassium level 7.1, tall T wave, wide QRS complex. So what could be? When first they develop tall, then wide QRS complex, and also there is another change. So there are some in the mechanism it is mentioned that first of all, when there is initially they develop 5.5 to 6.5 maybe peak T wave, then up to 7 they develop P wave widening, PR prolongation, okay, and then when 7 to 9 they develop arrhythmia, okay, bradycardia, and atrial fibrillation could be, heart block could be, okay, prolonged QRS could be, okay. So if you go through at 7.1, which changes are there? So up to 6.5, they develop tall T wave and then develop QRS prolongation, prolonged peer interval. But at 7.1, you will get heart block, okay. Even you can develop third-degree heart block also, complete heart block also, okay. Okay, so yes, I think it is third-degree heart block, and it is mentioned in the MRCPCH side. If you see this, you can understand. Sine wave develop more than 9 and ventricular fibrillation system. So if you read this, you can understand. How the dobutamine acts, dobutamine, how they do. Dopamine, dobutamine, but it's although pharmacology related, but we can discuss it here also. Yes, it stimulates beta-1 agonist receptor. So in case myocardial contractility, stroke volume, so cardiac output will be increased. The main action on the beta-1, it is discussed in the Science of Pediatrics books. We also discuss in our class how the dobutamine acts, dopamine acts. And some ECG related questions come in the TAS exam. I said that TAS exam could be ECG related. So very few questions, very basics. And then superior axis deviation is related with the ABSD. Another question came in the exam that what is the cause of hyponatremia in the PDA? Actually, when PDA related things, then PDA we used Lasix, okay, loop diuretics. It could be a cause. Okay, so every option is not here, so you should know. And in the PDA also, ANP will be increased. because when there's actual stretching, so it makes more sense than diuretics. Okay. Also, preterm infant, they have proximal renal tubulars immaturity, so it can decrease absorption of sodium. Also, if you can take that hypoxemia, respiratory distress, it can affect. So mainly we can take it here in. So if you go through this, then you can understand more why I am saying N is more important, because diuretic also can cause, but it takes time to develop. Again, ECG related when atrial depolarization, avinodal conduction, these are the things you should go through this. So cardiac catheter related interpretation was there, so you should go through. One questions was there. Okay. So please go through the cardiac catheter, our lectures. That was you can review this again, or just see the PDF file. Okay, so that you can remember very simple things you have to read. And I think 5 minutes required to read this PDF. Then you can answer all the questions. I'm very much confident. Okay. Here, most of the questions we discuss, okay, and most of the things are related with the, yes, that we already read. Clinicals related question more from here, because it's very old recall, okay, but everything having repetition. So here you have to give more emphasis on the tasks. I see tasks are having more questions from the cardiology. Okay. So hopefully you will go through all the things, and we will discuss in our next day respiratory systems. Okay. Respiratory system related. So before exam, complete your cardiology so that we can proceed the next chapters, and next day we have to read more, okay, because respiratory system, neurology, and then many systems are there that we have to read. Okay, thank you. Do you have any query, anything? Tomorrow, I want to take class daily. Otherwise, you will do not get time. So after I complete it within 13, then just give me 1 hour to 2 hours. Okay, same time, inshallah. 1 hour, 1.5 hour. Then you will read by your own way. Okay, but I suggest you don't go many various things now. Concentrate on your recall. Thank you. Thank you, everyone. Assalamu alaikum.